Hello, hi everyone. So this is the next part of the lecture with regards to complete dentures. And the last lecture we had covered the denture try-in appointment and what all to check in that and what all corrections needed to be done. And the last step in denture fabrication is the denture insertion, that is the denture placement, selective grinding, and the post-denture instructions that should be given to the. You are supposed to evaluate the process denture, that is after fabrication. You should analyze the fit of the fabricated process after keeping it in the patient's mouth. You should be able to describe all the steps following denture insertion, that is verifying the denture, intraoral fit of the denture, retention of the denture, aesthetics, stability, and occlusion. All these needs to be checked. You should also be able to describe what is clinical remounting or what is known as lab mounting and what is selective grinding in relation to denture occlusion. You should also be able to give elaborate and thorough instructions to the patient after denture insertion, because the success of the denture depends a lot on the instructions and what the patient expectations should be. You should also educate the patient about maintenance of the processes, that is after the denture insertion, the daily know-how to how to clean the denture, how to maintain the denture, what all needs to be. So this is probably the most eager and anticipated step, especially for you guys, the final year and the fourth year students, because this is probably your first patient that you're doing a complete denture for, and probably the first interaction with a live patient in prosthodontics. So this is a huge step, and the complete denture fabrication is not for the faint-hearted. It is a very complex process. It is not as easy as it is seen or made to believe. So you have to be aware of the physical, physiological, and psychological needs of the patient that need to be addressed with the denture. And this appointment involves not only the clinical procedures but proper counseling of the patient about the expectations, about the training or getting used to wearing the dentures, and how to care for the denture, because remember, it is a process just like any other processes, such as a maybe a missing hand, or a process for a missing leg, or an ocular processes or a ear processes. Every processes has a lot of psychological and social impact on the patient, and if done properly, it can really help and benefit and improve and enrich the quality of life of the patient. So this step is really important. So next, coming to the denture inspection. After the denture acrylization, after the deflasking, you remove the dentures, you trim, polish, and finish the dentures in the laboratory. That is prior to receiving it in the clinic. And at this step, you first check the fitting surfaces or the tissue surface of denture for any imperfections, such as cracks, fissures, nodules, any sharp edges that may damage the patient's soft tissue and cause pain and discomfort. Secondly, you should inspect the borders, that the denture border, as I always tell, should be like a fish belly. They should be rounded from the tissue surface, that is the cameo intaglio surface, to the cameo surface, that is a polished surface. They should not be sharp. They should not be what you call flat. They should be rounded. And then thirdly, you'll inspect the cameo surface or the polished surface of the denture, that it should be completely smooth. They should try to achieve a glassy finish with some amount of gingival characterization and stippling and scalloping, if it can be done. So, and any plaster or dental stone that may be stuck in the interdental embrasures or the gingival margins need to be thoroughly removed prior to polishing. And next is, so this is how processed denture should look like. It should have a nice polished glossy surface with proper carving and scalloping and stippling of the gingiva. So next comes the intraoral adaptation. After you're thoroughly satisfied with the processed denture, it is ready for insertion in the patient mouth, and you need to insert the denture. You need to inspect the fitting surface of the denture, whether it has any premature or pressure spots on the patient's residual alveolar ridge. And these pressure spots are difficult to find out, because unless a patient has already worn the denture for a day or two. So one way to identify these pressure indicating areas or any sharp extensions is by using a pressure indicating paste. This is first applied using a brush or a cotton bud on the tissue surface of the denture. This is a highly viscous material which has thixotropic properties, that is, it will flow under pressure. So then the dentures are inserted in the patient's mouth. The patient is asked to bite on the upper and lower complete dentures, and then after some time, after a minute, the denture is removed and inspected for any areas where there is no pressure indicating place. That is, any areas that are exposed, like it may be at the border of the retromolar pads, or it may be in the alveolingual sulcus, or maybe in the anterior or the label under the label flange of the mandibular denture, or in the mylohyoid area. So any of these areas need to be seen. They should be marked with a pencil, and then the pressure indicating paste is removed, and these areas are trimmed or relieved. Similarly, the denture border extensions are also checked. So, as I mentioned, the border peripheries and seal need to be checked. If you have taken an accurate secondary impression, which is seldom the case in the clinics, because you all are learning, and it is difficult to get thorough impressions. So, denture extension, the flange extension into the vestibules, the relief of the labial frenum, the buccal frenums, the telecomandibular raphe, and the posterior parietal seal all need to be checked, verified in the patient. You can use a periodontal probe to place in the patient's vestibule and measure the vestibular depth, and then similarly you can also verify it on the dentures using the same periodontal probe, or you can just simply insert the denture in the patient mouth and do all the border movements like you do in the secondary impression step, and you need to check visually for the relief or overextension of the denture borders, denture flanges, all these things in the patient's mouth, and any discrepancy should be relieved then and there. So this is the what we are talking about, the clinical steps of denture insertion, verification, and so next is we check for retention and stability. That is by using a pinch method, we try to pull the denture away from the denture bearing area to check if it is retentive. And like I mentioned, a try-in appointment, we can check the contralateral sides retention or the border seal by placing a finger on the palatal aspect of the canine and then pushing the denture outwards. And so this will give you a fair idea about the retention and the stability of the denture. So this needs to be checked properly and thoroughly at this step. And also we shouldn't panic, because sometimes the denture may not be as retentive during the denture insertion appointment, but slowly in a matter of 3 to 4 days or up to a week, the denture settling happens. That is, the tissue or denture residual alveolar ridges, they mold or shape according to the internal tissue surface of the denture because of the RLF or the residency like effect. And this in many patients, this will help in improvement of the retention and stability of the denture. So next step, also of course we have to check for aesthetics, the lip fullness, the labial full, the buccal fullness, and the incisal visibility depending on the age of the patient. And if the flanges are too thick, they should be trimmed and thinned out at this stage. Next, coming to the occlusion. So this is basically a very important part of denture insertion, as faulty occlusion will result in instability of the denture, will result in soreness of the denture bearing area, and will result in poor patient compliance. So the causes of occlusal discrepancy could be that there was an error in jaw relationship, that is, there was slide in centric, and maximum intercuspation do not coincide, and this you fail to check this at the trial appointment. Also, it could also be due to the errors in mounting. That is, while on mounting on the articulator, there was some displacement or shifting of the models with the wax rims, and this would also produce errors, changes in the supporting tissues, because the models that cast are made of gypsum, they are hard, whereas the denture tissues are soft and covered by mucous membrane and connective tissue. So because of the settling of the denture, some errors in occlusion are definitely noted in the patients. So, and in some patients, there may be flabby tissues or knife edge ridges or bone resorption in certain areas that may cause the shifting and tilting of the denture base, that is not actually visible to the eye, but it could result in errors in the occlusion. So these need to be verified, and the correction either can be done clinically by placing the dentures in the mouth and then and they're verifying and adjusting the denture occlusal prematurities by selective grading. Or a more predictable method is what we call as a clinical mounting or a lab remounting. So here in clinical correction it is fairly easy. You place the articulating paper bilaterally on all the posteriors, that is bicuspids and the molars, and you take a bite in the centric, and then you tell patient to do eccentric movements, and you see whether all the teeth have uniform bite marks or the markings from the articulating paper. Because if all the teeth have markings, that means your VD is correct, and the markings for the mandibular posterior should be on their buccal cusp, and on the maxillary teeth it should be on their what do you call the palatal cusps. So these if this is not the case, then like here heavy occlusal contacts are seen on the maxillary posteriors but on the buccal cusp, which we do not want. So this needs to be adjusted by selective grinding using acrylic trimming burrs. And this can be done as I mentioned using articulating paper or by using softened wax and asking patient to bite in the softened wax, and wherever the wax is perforated those areas are marked and they are selectively ground. We also have special articulating papers which are U-shaped for easy adjustment or ease of uh, correction of the occlusive prematurities, which can also be used. So what are the disadvantages of intraoral correction? See, the intraoral correction is a very straightforward and simple and quick step that can be done then and there at a chairside. But because of the resiliency and displacement of the supporting tissue, that is soft tissue under the denture, some premature contacts may not be visible at that time. And of course, it is not possible to observe all the discrepancies throughout the arch because of the poor visibility in the patient's mouth, the presence of saliva, and occlusal interferences can cause pain, which may make the patient avoid that side. So the patient may, if the patient suppose is having pain on the left side on the retromolar pad or on the tuberosity area, then he may not bite properly on the left side, and he may try to shift his mandible to the right side, and you may get occlusal heavy contacts or discrepancies more on the right side. So but this would actually not be the case if this discrepancies are being checked using a clinical mounting procedure. So the next procedure is the extraoral clinical remounting procedure. So in this procedure, basically what you do is you insert the dentures in the patient mouth. You first relieve all the painful areas or any overextensions and all those things. And then when you're ready to check for the occlusion, you take intraocclusal bite between the upper and lower complete dentures, and then you do a phaseboard transfer for, and then using the phaseboard transfer the upper maxillary denture is mounted on the articulator, or if you already have existing or duplicate models of the patient, the cast, and you can just place the dentures on those cast and do the remounting using a phaseboard transfer. Then using interocclusal record, the mandibular denture is also mounted, and then the balancing and selective grinding of the contacts of the occlusal prematurities is. So the basic rule here is called bull. That means buccal upper and low lingual lower. So basically, the as I mentioned earlier, the palatal cusp in the maxillary are the primary cusps or the holding cusp, and in the mandible they are the buccal cusps. So these cusps should not be modified because you will then be altering the vertical dimension of occlusion, and you will disturb the centric and the balancing contact. So that's why you have to modify the opposing cusp. That is, in the maxilla you will adjust the buccal cusp, in mandible you will adjust the lingual cusp. That's why it's called the bull law. So next, after occlusal discrepancies and selective grinding is done, you are satisfied, and then you have to give the post-denture denture insertion instruction. That is how the denture should be inserted and removed, what all the patient should expect from the dentures. Patients should have a realistic expectation that a denture is a prosthesis. It is not their natural teeth, and they have lot of limitations, and they take time to get adapted to. So the all these things should be explained to the patient. Of course, you have to share the post care instructions with the patient. So they should tell the patient that initially he'll have an awkward feeling, a feeling of heaviness, feeling of foreign body. There will be excess salivation. His appearance will be changed. He's not used to seeing his face like this because he has been edentures for a long time. His cheeks and lips have lost their tonicity, and now suddenly he feels lip fullness, cheek fullness, and the facial features they change. So, and his speech will be slurred and altered because of the palatal vault of the denture and the lingual phalanges of the lower dentures, and because of the placement of the teeth on or facial to the ridges. So this will alter speech, and it will take some time to get trained to these things. So patient should be advised to read a magazine or a newspaper and practice to talk by looking in the mirror, so that he can get adapted better, because tongue is a very resilient muscle which has a very good memory, and it can be trained very easily to the speech pattern of the new denture. Of course, if there has some serious issues like pronunciation of sibilants, labodental sound, linguodental sound, bilabial sounds, these need to be corrected in the denture. But other than that, speech will fairly return to normal. And as I mentioned, there is excess salivary flow. So all these issues will slowly resolve over time. Patient should give at least 3 to 4 weeks to get adjusted to dentures. He cannot be impatient and cannot be unrealistic in his expectations of the dentist and the denture. So eating now, this is one of the major reasons that patients seek treatment for the denture fabrication, that they are unable to eat solid foods and their health has taken decline. So that's why you need to advise patients that they need to train first in order to be able to chew and eat properly. So this will usually take 6 to 8 weeks for him to be comfortable. Initially, patient should start with soft diet, like anything which is non-fibrous, non-chewy, and does not require too much effort. And any food that patient is eating, whether it is pizza or whether it is apple, banana, or any kind of fruit, they need to be cut into small bite-sized pieces and should be eaten with a spoon and fork. And the patient cannot bite directly into the food like he used to with his natural teeth. So, and the tissues first need to get used to the feel of the dentures, the pressure from the denture, because you remember the pressure is being transported from the denture to the denture bearing mucosa, and then from there it is transmitted to the underlying residual alveolar ridge. So, this is bound to create some soreness, ulceration, and discomfort and. So after all these things are done, recall is done, and the patient dentures are adjusted. You also need to give care instructions, like hygiene is of paramount importance. The dentures need to be brushed every day and cleaned every day, just like you would your natural teeth. But the difference being that dentures should be cleaned with a soft denture brush and not with a hard bristle brush, and not with toothpaste, but they should be cleaned with a mild soap or a liquid soap or soap wash. So, and the next thing is the dentures should always be cleaned thoroughly with water, and preferably a cleansing agent such as denture cleansers. Like all nowadays, all the denture product manufacturing companies, they make denture cleansing tablets or denture cleansing solutions. So basically, the denture should be occasionally placed in a water bath containing commercial grade denture cleansing tablets, such as which are mainly contain sodium perborate, and denture usually can be left from half an hour to overnight. But it is preferable that dentures not be kept overnight. Although I have written here overnight, but it is preferable because to not keep the dentures overnight. But half an hour is more than enough for the cleaning of the dentures. So another thing is that, and even in spite of cleaning the dentures thoroughly over the years, the denture may attract calculus and tartar and other deposits. So these can be removed by placing the dentures overnight in white vinegar, that is the regular synthetic vinegar which we get in the store shelves, and this will help in dissolving the calculus deposits. So this is with respect to denture care instructions, because remember, if proper care is not taken, then it will result in denture stomatitis, candidiasis, and inflammatory papillary hyperplasia, and all these conditions that affect the oral mucosa. So, as I mentioned, recall should be done first recall is done within the first couple of days, that is first 24 to 72 hours, and then second recall is done preferably after a week. And usually patient will not have any complaint after the second visit, but if you desire or want, a third recall can be kept at 3 to 4 months, and yearly patient should come for the checkup and a thorough examination. Usually dentures need to be replaced every 5 years, or at least they should be relined every 5 years, owing to the continuous resorption of the residual alveolar ridges underneath. So with this, we come to an end. And in summary, denture insertion appointment is very important. I don't need to stress the how important this step is. And this is the culmination of all your efforts of the previous 4 to 5 appointments that you have been doing. And time spent by the dentist in this appointment will go a long way towards the success of the denture, because you see, a denture patient is like I would like to compare a denture patient is like a psychiatric appointment. You're not only giving processes to the patient, but you're changing his life, you're changing his quality of life, you're changing his smile, you're rehabilitating him, just like a prosthetic leg or a prosthetic hand rehabilitates a handicapped person. You're rehabilitating them. So with these things, with rehabilitation comes many social and psychological issues, and all these need to be gently addressed in each appointment. And in the final appointment, the expectations, the training involved, all these should be discussed with the patient, so that he is aware of all these things, and he is motivated and he is patient to overcome all these odds and have a successful denture. Because just success of a denture is not just in the hands of the dentist, but both the dentist and the patient determine the success of a complete denture processes, or for that matter any oral rehabilitation procedure. So thank you all.